this talk. So I don't have any conflicts of interest, and I will start with my conclusion. And my conclusion is this. I think it's extremely unlikely that calcium is beneficial for hyperkalemia. And before I sort of go into the reason for that, I think we have to sort of have the same premise. And my premise is very different from Jas. Jas says that, well, he doesn't really know if it works, but we already use it. Why not just keep doing it? That's not my premise. My premise is that drugs are ineffective until we have proven that they work. So if something doesn't work, we shouldn't be using it. And it doesn't matter whether we have been using it for 50 or 100 years. So if you're not on the same page with me there, I think it would be very hard for me to convince you otherwise, but that's my premise. So of course, we saw this slide. This is from the European Resuscitation Council, very similar to the one that Jas showed. And you can see that calcium is right up there. First line treatment for severe hyperkalemia. So my question when I started looking into this is like, why is it there? Like how did we get here? How did we end up with calcium as the first line treatment? Here, there's a bunch of guidelines. I've just focused on some of the major ones here. So these are the European Resuscitation Council, the American Heart Association, and then the UK Renal Association. Let's go through them one by one. This is the recommendation from the European Resuscitation Council, and Jas is on this publication here. It says that there's no strong evidence base, but we should give it anyway. Then they provide a citation. They provide a citation for this paper. This paper doesn't have a word about calcium in it, so I don't know. Not much evidence there. Then I went to the American guidelines. Okay, what do they say? Well, they say we should use IV calcium. What about what's the citation here? Oh, it was their own guidelines from 10 years ago, which had no citations. So far, not great. Then we go to the UK Renal Association. They also say we should be using calcium. It's like, okay, there must be a good reference here. Okay, they actually referenced a very well-done review by the Cochrane Group. Not a single trial of calcium included in that study. So we have guidelines upon guidelines that just cite nothing, that has nothing to do with calcium. So I don't know where it came. So I thought, okay, I have to dig much, much deeper to figure this out. So like Jas, I went back to the historical papers. And this is the Ringer paper that says that calcium, in the first sentence here, restores good spontaneous beats, which will continue for a long time. However, the part that is always left out of this discussion is what's right underneath, where he says, but if you give too much calcium, the heart stops beating. And we have no clue what the right amount of calcium is. And then, okay, maybe there are other papers. Yes, there are these two. Jas mentioned one of them, the Winkler paper. And I've been trying to look at these papers, and I can barely figure out what they did. The methodology is so poorly described that you don't know what the dose was, what kind of animals they used, how many animals they used. It was obviously not randomized. It was not blinded. And then, okay, maybe there's something else. And then there is some of the studies here that was also mentioned by Jas. It's case series. There's 5 patients in each of these groups. And they give monstrous doses of calcium that I don't think anyone would do today. This is the level of the evidence. Some of it is published more than 100 years ago, and the newest of these studies are published more than 50 years ago. If you're interested in sort of the history, there's a nice overview on this website here that goes into even more detail. So I thought, I must have missed something. I must have missed some fundamental important study. Why else would all the guidelines say that we should use calcium? So we did a quite ambitious systematic review. We looked at all interventions for hyperkalemia, so not only calcium. We searched 3 different databases. Unlike the Cochrane review, we were not only looking at randomized clinical trials in humans, because I thought we wanted the broad picture. So we also did observational studies. And we looked at in vivo studies in animals, so not in vitro, not where someone had taken out a muscle fiber or heart. We found more than 30,000 titles and abstracts that we went through. Out of that, we identified 5 studies that specifically looked at calcium. 5. Okay. Not a single of those 5 studies supports the use of calcium. What were the 5 studies? It was these. So there are 3 observational studies here. It's this one here, here, and here. None of them found a beneficial effect of calcium. Some suggested it was harmful, but there's a lot of methodological limitations to these studies. Some of them have also very small sample sizes. Then there's this one study in a pig model, no positive effect of calcium. And then there's the last study up here, which I actually thought was the most interesting one. So this is a small interventional study published in a Turkish medical journal. And I don't know why it's not published in Intensive Care Medicine or JAMA, because it's actually a really, really nice study that addresses a very relevant question. So they identified a little over 100 patients who had hyperkalemia, mean value of around 7, and ECG changes. So the exact population that Jas was advocating that we should use these intervention in. Then they found them, they took an ECG, they gave them calcium, and they took another ECG. So we would expect that something happened to that ECGs, because we all agree the one effect calcium is supposed to have is this membrane stabilization, whatever that means, but that's what it's supposed to do. It's supposed to change the ECG back to normal. That's also what we saw in the case series. So these were the findings. No difference in the T waves, no difference in the P waves, no difference in the PR interval, no difference in the QRS duration. So all the things that are supposedly because of hyperkalemia that should be helped with calcium, it made absolutely no difference. They did find some small difference in escape beats and first degree AV block, but it was not significant and definitely not clinically meaningful. So we wanted to look at this a bit more. So we, along with some colleagues in Aarhus, we did this animal model. So it's an animal model of hyperkalemia-induced cardiac arrest. So we basically give the pigs infusion of potassium, and that makes their potassium around 8 to 10. They don't have a spontaneous cardiac arrest from that, so we give a bolus, and then they go into cardiac arrest, either PEA or ventricular fibrillation or tachycardia. Then we wanted to test two interventions at the same time, so we looked at both calcium chloride and sodium bicarbonate. And this is not published yet, but has been accepted for publication. So it was quite an ambitious animal study, quite a lot of animals, as you can see here, and it was blinded and randomized. No effect of calcium whatsoever. You can see it on here on the left side. These two curves are not statistically significant and are not really different in any way. So it had no beneficial effect to give calcium for hyperkalemia-induced cardiac arrest. Sodium bicarbonate, on the other hand, actually worked in this setting, and we had more pigs who had return of spontaneous circulation. So it sort of proves that the model worked. We were able to show that an intervention worked, but not calcium. Okay, now I'm sure there's someone out there who's saying, but what about the physiology? I'm not great at physiology, but this is the proposed mechanism for why hyperkalemia is bad to the heart. Increases the resting potential, which means that you can get ventricular arrhythmia, for example. And the proposed mechanism is that calcium should sort of counteract these effects of hyperkalemia. That might or might not be true. I think that's for someone else to look into. But my point is that physiology is complex. Physiology is extremely complex. Calcium is used in almost every cell in the body. It's used for muscle contraction, the coagulation system. It's used in the brain. It's a mediator of ischemic reperfusion injury. It's used everywhere. So I think it's quite naive that we think that we have identified one little thing in the heart, the action potential. And if we take out a muscle fiber, isolate it, and put it in some water with some calcium and some potassium, that can then tell us something about the clinical management of these very complex patients. We don't know how the calcium is going to work in the rest of the body. We don't know how it's going to work in the brain, especially if there's ischemic reperfusion injury like cardiac arrest. And then we have to remember also that even if it actually does work, in the isolated muscle fiber. We have no idea about what the right dose is and how it should be administered. And remember this sentence from the early Ringer study back in the 1800s, that if you gave too much calcium, you killed the patient, you killed the heart. It stopped beating. So maybe it works if it's the exact right dose at the exact right time, but we have no clue what the right dose is. The guidelines right now recommend 5 to 10 millimoles. As you could see from some of the earlier studies, they gave much more than that, 5 to 10 times as much. So I don't think we know the right dose at all. Then some of you might say, but who cares? I mean, it's calcium, whatever, what can happen? I think I have two arguments against that. First of all, it's the first line treatment for hyperkalemia. And if it doesn't work, we shouldn't be using it. We should be focusing on other things, monitoring the patient, trying to lower the potassium, because we know how to do that. And that's the second line treatments here in this algorithm. And they actually do work. Insulin works, glucose works, beta agonist works, bicarbonate works in some situations. So we should focus our efforts on that if calcium doesn't work. And then, of course, I was a lover of calcium. That's how I started. I thought it was great. I thought we could save lives by giving calcium. And that's why we did this randomized clinical trial where we randomized patients to either calcium chloride or saline during out-of-hospital cardiac arrest. It was a double-blinded, randomized clinical trial. And it was stopped early by the Data Safety Monitoring Committee because there was a strong signal of harm. These are the Bayesian secondary analysis because I think they illustrate very nicely what the results were. So we have three outcomes here. We have return of spontaneous circulation, survival at 30 days, and a favorable neurological outcome at 30 days. And the results are very similar up to 1 year after the cardiac arrest. As you can see, there is a very high probability that calcium is harmful. So more than 90, and in some cases more than 95% probability that the risk ratio is below 1, meaning that calcium is harmful in this condition. So if we have an intervention that has no proven benefit and that it might have some proven harms in some conditions, we should stop using it. And the problem is that even though hyperkalemia-induced cardiac arrest is extremely rare, it's maybe 1-2% of all cardiac arrests maximum, calcium is used a lot. We don't have good data from Denmark, where I'm from, or from Europe, as far as I know. But in the United States, approximately 1/3 of all patients who have an in-hospital cardiac arrest receive calcium. So someone believes it's beneficial, and someone might believe they're treating hyperkalemia. So I don't think it's not potentially harmful to have it there in the algorithm if it doesn't work. As was mentioned previously, we also thought it would be nice to look at, okay, do we have some people in this trial with hyperkalemia? Unfortunately, we did not have blood samples before the cardiac arrest, and at arrival to the hospital, it's hard to tell whether the hyperkalemia was the cause of the cardiac arrest or the other way around. We only had 3 patients who had a potassium above 7, I think. So we couldn't do that, but we thought, okay, we could look at some of the ECG characteristics that are at least traditionally been associated with hyperkalemia. So that's something like prolonged QRS, changes to the P and the T wave. And so we tried to do some subgroup analysis, challenging, of course, and could not identify any subgroup based on these ECG characteristics where calcium was potentially beneficial. So I think it's fair to conclude that calcium is unlikely to be beneficial. I'm not saying it's not beneficial. I think the evidence so far suggests that it's not beneficial for hyperkalemia. And I think as a society or as a group of clinicians and researchers, we need to step up our game. I mean, we cannot base our clinical treatment on studies that were conducted more than 100 years ago. That's just not good enough. So I think we need to address these things, whether it be hyperkalemia, hypernatremia, or anything else. We need to do better studies. And I'm not advocating that we should do double-blinded randomized controlled trials for everything, because we can't. No, we should do good observational studies, well-controlled animal studies, and then, if possible, some clinical trials. That's it. Thank you.